Unfortunately, Alzheimer's disease is not an uncommon problem. It affects people as they age, and nobody can reverse the tide of time. Individuals over the age bracket of 65 should have an annual cognitive examination. And part of the reason behind this is that we definitely know that the overall prevalence of Alzheimer's disease is maybe about 5 to 7% in individuals over the age of 65. However, by the time that somebody reaches the age bracket of 85 or older, 50% of people will be impacted by this problem. In fact, the Alzheimer's Association has forecast that if at the present time every 68 seconds somebody is diagnosed with Alzheimer's disease, by the year 2050 rolls around, it's going to be every 33 seconds somebody developing this problem, which then means that we'll either know someone in our family or we'll have direct contact with somebody with Alzheimer's disease. And that means that this is a horrible scourge that's going to be affecting a bunch of people. Why do I say that? Well, as doctors, we've managed to do a better job about addressing medical comorbidities, so people live longer nowadays than they did back at the turn of the century when this illness was first described by a Bavarian psychiatrist by the name of Alois Alzheimer. And one very important thing is that still, it's a 100% diagnosis if we scoop out some brain tissue and look for the pathognomonic features associated with the illness. Nobody, however, is going to really do that. We know, however, that based on our clinical acumen, we are going to be pretty sure most of the time when we diagnose Alzheimer's disease, having discarded common things that might be mistaken for it. For example, somebody that has an infection, somebody that is deficient in vitamins, somebody that might have depression. So it's really primordial that we address all of these particular points first, and then recognize that this is a very common problem. Now, at the present time, there is no way of curing this illness, which means that an early diagnosis affords the best opportunity that somebody may have. So when in doubt, getting oneself checked out and seeking one's own doctor would make the most sense. Well, we in the past would have thought of it as a diagnosis of exclusion. Now we think of it as a diagnosis of inclusion, meaning that we're obviously going to rule out the common culprits that might look like it, but we're definitely going to have it in consideration because we've grown in sophistication in our understanding of what's going on. And in fact, much of the research work that's being done right now is earmarked at the very early staging associated with the problem. In fact, we are truly doing a prevention study at the present time where we're looking at individuals that have the highest degree of susceptibility to this problem, meaning individuals who happen to be homozygous carriers of the apolipoprotein 4 allele, meaning both mom and dad gave them an ApoE4 allele, because those individuals have a higher likelihood compared with, again, the average bearer of developing Alzheimer's disease. So the study that we're doing is taking a look at those individuals between the age bracket of 60 up to 75 and treating them proactively with either an active immunotherapy that gets rid of beta amyloid plaques in the brain or a beta amyloid converting enzyme inhibitor, which would do a similar function. And what we're trying to do is avoid the onset of either mild cognitive impairment, which appears to be the very earliest staging associated with memory problems that might not go away, or the very earliest form of Alzheimer's disease. And in that study, if somebody were to convert to either MCI or very early Alzheimer's disease, we just automatically start treating them because, again, part of the initial portion of that trial is seeing whether treatment or non-treatment afford protection from the development of this problem. So that's why I mentioned it's a diagnosis of inclusion. In the past, yes, we would have said a diagnosis of exclusion. So some of the key things are that, even in speaking about very early Alzheimer's disease, we're looking at different interventions that might help us out, whether it be the aspect of going after inflammatory process by the use of, say, immunoglobulins, or maybe even targeting a possible regeneration of cells with stem cells And again, if you take into consideration that pluripotential cells may actually evoke a nice way of restoring tissue that would have been lost secondary to a neurodegenerative condition, that's really exciting. But obviously, we're also looking at symptomatic treatments that piggyback onto treatments that are currently available. So probably the most important thing that I would want people to be aware of is to not shy away from this diagnosis. Being an ostrich and burying one's head in the sand is never going to fix this problem. Being proactive and knowing, if I've had a family member with this problem, should I be getting checked out and tested? I would say absolutely. There's no folly in that. I mean, the best news is, hey, there's no problem. We're fine. And by the way, that's also going to incur some of the things that we typically advise individuals about. What's healthy for your heart is always going to be healthy for your brain, meaning nutrition that makes sense, a Mediterranean diet, appropriate hydration, which a lot of people neglect, staying active physically and mentally. Again, all of these things just make sense, but oftentimes we just don't apply ourselves. And for the individuals that are worried well, such as, say, a family member that doesn't really have a problem, if you ask them to exercise their brain in ways that they've not done before, such as learn a new language or pick up a musical instrument and learn something that they've not been able to do before, oftentimes people will balk and say, that's too hard. Well, that's the point. You want things that are going to be difficult that now you're having to retrain your brain to work in ways it's not done so before. And by doing that, you're creating cognitive reserve. What's the worst thing about that? The biggest downside is that you'll become more interesting in a conversation with other people. So, if you just think of it in that way, rather than being ashamed or feeling stigmatized that there might be a particular problem, being proactive is probably the best approach that we can think of right now. And those would probably be some of the more important salient issues that I've picked up over the past close to 25 years that I've been involved doing investigational research work in this space. So there are many ways of assessing somebody that might be having memory problems. By far, one of the most accurate and, again, specific ways of trying to feel out whether somebody has a memory problem or not is the Montreal Assessment for Cognitive Abilities, or the MoCA. It's a free scale that the folks out of Montreal put out there, and it's pretty easy to get. Now, you basically hop online, you download a PDF file, we can utilize it. There's no copyright associated with it, and it'll give us a better feel of what that individual may not be able to do, and it'll certainly also open up additional dialogue about the possibility of needing to do more rather than less for that particular person. It's really important that we get a feel of what's going on. We're obviously not just going to be diagnosing people with Alzheimer's disease out of the blue for no reason. There's always got to be a bias behind it. So a combination of different symptoms can be telltale of this problem. Part of the problem, though, is that many times individuals feel that normal aging is associated with memory loss. To a degree, they're correct. There's a term called benign senescence or age-related memory decline, which means that past our mid-20s, all our memories start to slide. This becomes a little bit more pronounced in our mid-40s, so it's not uncommon for people to all of a sudden say, what's the name of that thing? Oh, it's that. So that's not uncommon. But if all of a sudden the individual is thinking, what's the name of that? And they just can't remember. And no matter how hard, and even after some time has passed, they've still not remembered, that's problematic. Or the individual that keeps asking the same question over and over, or again, repeating themselves, now creates more of an annoyance with family members. Because remember, Alzheimer's disease is a condition that begins in an insidious fashion. And that term is unique because it basically means that it's crept in very slowly, very gradually to the point where it's not been detected, and it oftentimes gets missed by individuals that are closest to the person that becomes affected. And that's really germane to this because, you oftentimes have family members that say, you know what, there's really no problem, but, it might not be a bad idea to get this checked out. And then once you actually start digging in, you kind of figure out that they should have brought their loved one 4 or 5 years earlier. And oftentimes there's been a lag that might have actually allowed us an opportunity to catch this disease state at an earlier point and to be maybe more successful at intervening and addressing it. Because what happens is, as you lose cells in your brain, you can't recuperate them again. So what you lose is gone, and why not protect what you have before it gets lost? Well, someone typically walks in, and usually it's going to be at the behest of someone else. It's usually going to be a family member because unfortunately that individual has already crept further into the disease state. You'd be shocked. 2 out of 3 individuals that come in and first get a diagnosis are already in the moderate staging associated with the problem. And so what we now need to do as doctors is to create more of a message that it's important to come in early. If there's even a degree of suspicion, get it checked out. Yes, it could be that your vision or your hearing's affected, or the individual has an underlying affective problem like depression or anxiety that needs to be dealt with. Or maybe there's a vitamin deficiency like vitamin B12 or folate, or even vitamin D that might actually be too low. But you also touched on a very important point. There are certain issues associated with pathophysiology, including the aspect of the olfactory bulb. That is one of those senses that, what has an immediate reach into the brain, and oftentimes anosmia, or the inability to detect odors. And by the way, that'll also affect your taste, because your taste is also, again, supported by your sense of smell, become affected in individuals early on as well. So there are different factors that we key in on, and obviously if we've discarded other potential issues from more esoteric things like normal pressure hydrocephalus, or even a tumor or a stroke, or any other things which we'd be able to pick up through a neurological examination or through different types of tests like an MRI scan or different labs, obviously that'll help us out. But say all of a sudden we had somebody that we suspected a memory problem in, the MOCA would certainly help us with that.